today I will talk about functioning of emergency department of a hospital or emergency room. This is part of my series of lectures on hospital management. This is my lecture outline. First of all, I will talk about emergency room working and design requirement. Then I'll talk about key performance indicators, service related and academic related key performance indicators. So, emergency room working and design requirement. Emergency department is also known as emergency room. Emergency department is for treatment of cases of acutely ill or injured patients, hence also known as emergency and accident care. Emergency care can be considered as threat to life or limb requiring immediate attention. Emergency care must be available to all members of the society, and every patient is entitled for prompt, courteous, competent treatment at any hours. So this is equity and access related to emergency room. Emergency department of a particular hospital must network with emergency department of other hospitals so that patients may be referred and referrals may be taken from other hospitals. Emergency department have a key role in disaster management, as we will see later. So emergency services have these stages. There is a stage of patient arrival at reception. There is a stage of medical care. There is a stage of nursing care. And there is a stage of support and diagnostic services or diagnostic tests. And finally, there is either discharge after treatment or death or admission of the patient in the hospital. In case of disaster, the steps are similar except for the triage stage where the patients are classified into various categories of urgency. The process flow of emergency room is, first of all, there is evaluation of patient and there is decision making which requires support of the clinical laboratory and radiology services. Then there is treatment of patient which require support of pharmacy and or blood bank. And finally, there is disposition, that is discharge, death or admission of patient. Emergency conditions can be listed as accidents and trauma cases. Accidents may be road traffic accident, industrial accident or natural disasters. Then there may be medical emergencies, surgical emergencies, pediatric emergencies, ophthalmic emergencies, ENT emergencies, orthopedic emergencies, which include accidents and trauma care, and obs-gynae emergency and psychiatric emergency. These two require privacy. And there may be cases of poisoning, burns, drowning, snake bite, heat stroke, cold injury, blast injury, etc. Emergency care can be classified into four types. Type 4 is referral emergency facility. So it is a first aid service. Type 3 is standby emergency facility. That is for primary health center or community health center level. Then type 2 is basic emergency facility for a general hospital. And type 1 is major emergency facility in cases of a teaching hospital. Design considerations. So relevant sayings are that design follows the function. So design must be based on the proposed function of the unit. And the second saying, which is important, is that more you perspire in peace, less you bleed in war. So planning is more important. Then there are certain key questions which include, will the hospital provide pre-hospital care? What is the type of hospital, whether it is a general hospital, specialty hospital, multi-specialty hospital, or will it handle trauma cases? So the design is based on answer to these questions. Design team should include emergency physician, nursing administrator, chief architect, engineer, hospital administrator, and if possible, potential clients or patients. Architectural design can be core type, where the treatment area is central, or arena type and corridor type. Corridor type, there is corridor in the center and treatments on either side. So location of the emergency unit or emergency room or emergency department in a hospital, it should be situated at the level of ground floor. It should have a separate entry and exit. It should be easily accessible from Main Street. It should be distinctly identifiable with a properly lit signboard. And there is close relationship with support services, and support services for emergency room include services of a clinical laboratory, radiology department, blood bank, pharmacy service, operation theater complex, intensive care unit, and OPD. OPD should have a restricted communication uh, with the emergency room because sick patient can be transferred from OPD to emergency room if required. So the traffic flow can be external or internal traffic. Internal traffic is from the screening area to treatment area or to disposition or to observation, and from observation to either admission or discharge and death. And there are support services. So this is a flow of traffic. Then sections of an emergency room include entrance with trolley or wheelchair bay. This is very important. Entrance, as we have seen, should be separate. It should have a ramp facility and there should be trolley and wheelchair available. Then reception area, then screening area, then observation area. There may be few or more beds in the observation area. Then treatment area and nursing station. Then resuscitation area. It should be a enclosed space. Then a triage area, which is useful in case of disaster management. And doctor's duty room, store room, clean and dirty utility room. There is a need for security room and police post because of the arrival of medical legal cases often in emergency. Then there should be attendants waiting lounge. Then there should be meditation area, and there can be telemedicine facility for medical education. This is the organization chart of an emergency room. There is a chief medical officer who is in charge of emergency room, and then there are nursing officers, resident doctors, grief counselor, and medical social worker. Under nursing officer, there are nursing staff, nursing attendants, and technical staff. Then how to identify expected patient load. These are the methods to identify the expected patient load of hospital or emergency room or OPD or a laboratory. So very important is that we can make use of statistics of other similar hospitals in similar demographic area. We can undertake a community survey. We can study the disease profile of the population of the catchment area, and we can study the socio-demographic profile of the catchment population. Now about key performance indicators. I have divided key performance indicators into service-based or service-related or academic activity-related. So service-related key performance indicators include input indicators, service structure indicators, service process indicators, and service outcome indicators. Input indicators include total number of emergency room visits, average daily emergency room visits, percentage of leaving before screening, percentage of leaving without being seen, percentage of revisits to emergency room within 3 days or within 7 days, average emergency room patient acuity level, differential percentages of emergency room acuity levels. Then service structure. The medical doctors working in emergency department should have one or more certification. and the benchmark is 80%. Then minimum nursing to bed ratio in red zone, uh, and the benchmark is 1 is to 2. Minimum doctors to bed ratio in red zone, and the benchmark is 1 is to 3. Minimum duration ambulance downtime annually. The It should be less than twice breakdown per ambulance per year. Annual budget allocation for point of care test and amount of personal protective equipment provided and supplied annually. And these two should be adequate as per the requirement. Then service structure also include average number of active emergency room beds, average number of emergency room staff, ratio of daily emergency room patient to emergency room beds, ratio of daily emergency room patients to emergency room staff. Then service process indicators include door to time to be seen by doctor or nurses in cases of red zone, yellow zone, or green zone. And desired are immediate, within 30 minutes, and within 120 minutes. Then door to CT scan for CVA patients within 30 minutes, door to needle for thrombolysis in CVA patients within 90 minutes, door to thrombolytics for AMI within 30 minutes, ambulance response time within 15 minutes from call received at dispatch center for hospital-based ambulance services, number of working hours per week for medical officers, maximum 70 hours per week, and in case of India, there is a Indian Factory Act where the maximum limit is 48 hours per week. The number of working hours per week for nurses and the maximum 60 hours, and hand hygiene practice among staff, 100% compliance. Then other service process indicators include length of stay of all ER patients, length of stay of patient discharged home, length of stay of patients admitted to hospital, and percentage of emergency room patients with length of stay more than 6 hours. And then other is average number of emergency room patients waiting for treatment, average registration time, average arrival to trials time, average trials to bed time, average bed to doctor time. So these are certain time intervals. Then other indicators include average door to doctor time or waiting time, then average doctor examination to decision time, that is treatment time, and percentage of patient leaving before complete treatment, emergency room lab request turnaround time, emergency room radiology request turnaround time, emergency room medications request turnaround time. Then there are certain outcome indicators which include percentage of success thrombolysis in AMI, percentage of success thrombolysis in CVA, staff happiness index, number of patients public complaints, incidence of needle prick injury, incidence of nosocomial infection among staff. Other service outcome indicators include doctor decision to patient discharge, doctor decision to patient admission, percentage of ER patients admitted and discharged, average number of ER patients waiting for admission, average available inpatient beds, average available ICU beds. Then key performance indicators related to academic activity, ratio of lecturer to trainee in emergency medicine, ratio of lecturer to undergraduate in emergency medicine, ratio of lecturer to houseman in emergency medicine, and percentage of lecturers in emergency department who hold research grant at any time, percentage of lecturers in emergency department with subspecialty certification. Then academic process indicators include annual CMERs among the postgraduate Masters of Medicine emergency, then the undergraduate doctors, then houseman or junior resident doctors, then teaching facilities and infrastructure downtime, that is lecture theater, and the it should be less than maximum 2 times breakdown annually. Then academic outcome indicators include number of publications produced by a lecturer annually, percentage of postgraduate emergency medicine who qualify at stipulated time, percentage of housemen who passes the rotation at stipulated time, percentage of postgraduate emergency medicine who are able to complete dissertation at stipulated time, percentage of postgraduate students, masters in medicine satisfied with the residency program, percentage of undergraduate students satisfied with rotation program in emergency department. So this is all for today. Thank you very much.